Okay, so now that we've gone over the logic model and all of the components, the SWOT analysis and the resources involved in getting the care management plan to work, we look at the logic model framework here with this worksheet, and we can see that the program title is Continued Treatment for Incarcerated Substance Use Disorder Patients Transitioning to the Community. So what is the situation statement or the problem? Not all incarcerated SUD patients paroling to the community have established follow-up appointments with outside providers. We learned that in the beginning of the presentation, only 50% have established appointments, and our goal is 95%. We did establish, as we mentioned, informatics database within our charts and our EHRS and working with IT. So as we look at the inputs here, we'll notice that we talked about the staff is a vital part of this, with the volume being so high and care management and care coordination requiring a lot of time to do the appropriate communication, to research the chart, to speak to providers, to link them to appointments. We definitely need the right nurses, the right amount of nurses. We also need to make sure that the right staff are consistent. We also need to make sure that our SUD providers in the community are expanding. We need to make sure that our transitional care network that is linking our patients is continuously improving in efficiency. We need to provide fiscal support for those areas that include medications, having the right staffing package. Our informatics team needs to be 100% involved in pulling the data necessary to measure the transitional performance from this care management plan. Our medical coverage for our patients has to be established. That's Medi-Cal. That is done by a third party, which is why it wasn't a big factor in improving this particular care management situation. And our MAT meds and CBI providers, those are definitely part of making sure that a patient is stabilized before they transition into the community. So the outputs are the relationship, the activities that are happening. Well, we're screening, we're assessing, we're providing treatment at the facility, at the institution before they parole. And then we're providing the direct handoff to the community with an established appointment for not only substance use disorder treatment, but also for chronic care services. This requires participation by the primary care nurses, our social workers, our physicians. The discharge planning nurse is the vital component. The Department of Parole, the parole agents, our community MAT, CBI, and the chronic care providers. The outcomes, the short-term, medium, and long-term. The short-term, of course, is to prevent overdose. We really don't want our patients leaving the facility and overdosing within 2 weeks of paroling, as the research and the evidence demonstrate. We want to maintain sobriety. We want peer and family support. We want to secure shelter. We want to secure Medi-Cal coverage, secure transportation, SDI fiscal support in the initial stages of leaving an incarcerated situation. We want to attend the first MAT provider appointment, and we want to attend the first psychosocial cognitive or CBI appointment that goes hand in hand with substance use disorder. And we also want to make sure that any type of mental health appointment is secured as well, and that they attend that as well. Again, that wasn't a big factor for this, but I have to mention it because it is part of the total plan of care. The medium term, we do want to make sure that we're preventing the relapse. We want to make sure that if we prevent the relapse, it'll prevent the overdose, is what the theory is in a lot of research. The continued MAT treatment, continued CBI treatment, enroll in technical programs, job programs, obtain employment, obtain education, high school diploma, prevent recidivism, stabilize, continue the road to recovery, and hope that with all of these interventions combined in a whole person care environment, that they're rehabilitating and not coming back to the institution is that long-term goal. So again, complete remission, psychosocially stable, independent patient who is not returning to the institution due to recidivism from high-risk behavior. The assumptions, well, SUD treatment from primary care team during incarceration leads to remission and increases rehabilitation as patient transitions to community. Discharge planning leads to continued care with SUD specialists to prevent relapse, overdose, recidivism, and rehabilitation is in the assumption box. And I just said that as I was talking about outcomes. So it really tells us that those are completely related. The external factors, we have to understand that we are relying on the outside community resource to definitely continue with that road to recovery. We do want to make sure that in the outside environment, they have some social support, they have somebody they can count on. These patients don't have families, so we're hoping that social services continue with the care of these patients. And as I mentioned before, if we don't have whole person care needs secured, which does include some type of fiscal support, transportation, housing, jobs, we're not going to be very successful with these patients. So that is the logic model in a worksheet here. It is the framework of this entire care management plan, and we do hope to improve it with all of the resources that I mentioned previously, and we will monitor this plan with all of the data performance indicators that we've established.